Today I'm going to talk about insulin therapy. This is the slightly busy slice showing the peak and the duration of usually we use usually the insulin we use every day. So on on the left corner hand, you can see that there's the very fast acting insulin, rapid insulin, aspart, lispro, leucine. Actually, the human inhaled insulin is no longer available and we stopped using it since 2016. They have very quick onset. You can see that within 30 minutes to 1 hour after injection. So these are the insulin we call they need to be given with the food. So we call they are prandial insulin, like our Novo Rabbit. And another short-acting insulin is the name we usually use the traffic. A traffic peak is slightly later than Novo Rabbit. The peak reached around 1 to 2 hours. So that need to be given 30 minutes before eating food. So they are also the prandial insulin. These insulin cannot be given without mealtime. And you can see that this traffic duration of action is around 8 hours. So that's why we need to give 3 times with breakfast, with lunch, and with evening meal. So this Novorapid and this is Actrapid. These are the two main insulin we are using with meal everyday life. Can be given 3 times a day with meal. Usually they are clear, colorless insulin. Can be given intravenously while we preparing for insulin we use in fixed rate insulin infusion intravenously or variable rate intravenous insulin infusion. After that, this red line is the mix of the atrapid or novorapid with intermediate acting humulin I, the mixed insulin. So because of the mixed component of the short-acting insulin, that need to be given with mealtime. Usually we have the name with the humulin mix 30, humulin mix 50. So by the name, the humulin I is mixed with short-acting insulin in a ratio of 30/70, called the humulin mix 30. And when the short-acting and the intermediate acting component is mixing 50/50, it is called humulin mix 50. That means that humulin mix 50 has the 50% of short-acting atravic and another 50% of intermediate acting humulin I 50%. So usually the the peak they start session around 2 to 3 hours and last for 12 to 20 hours. So usually we use this with BD dosing regime, usually given with a breakfast and evening meal. Usually, this type of BD dosing regime we usually use in type 2 diabetes patient. Another type of insulin, we know that human I alone without having the short-acting insulin. So human I, the peak action around 6 hours and lasts for 12 to 16 hours. That's why it can be given in the morning with a breakfast. It's not necessarily need to be given with a meal because there's no short-acting component. Or it can be given at bedtime. So usually we use the human I A unit in the morning, A unit at bedtime. So in regards to the long-acting insulin, most commonly we use the glargine. Glargine lasts for roughly saying 24 hours, but it can be longer. If we use the concentration of U300, it can last to up to 36 hours. You can see that these long-acting insulin, glargine, it doesn't have peak like this other insulin. So glargine is very safe and rarely cause hypoglycemia. And we can use as a once daily insulin. Another longer acting insulin, longer than glargine, is Degludec. Degludec sometimes we can use in the poor compliance patient every 48 hours. We also have a Didamia, another type of long-acting insulin. But as from the graph, you can see that there is not peakless. There's some peak by the Didamia around 7 to 8 hours. And its action can last for 12 to 20 hours. So sometimes we use the Didamia once daily or twice a day, like Himalayan eye. These are some example of everyday use insulin pen that we all know that. Novorapid, Actrapid, rapidly adding as part. So this is the mixed insulin, the Humulin mix 50 or Humulin mix 30. So 30, the lower number is for long acting. Higher value is for short acting. So for example, Humulin mix 30. 30 stand for Humulin I, intermediate acting, 30%. For example, every 10 unit of Humulin mix 30 contain 3 unit of intermediate acting and 7 unit of extravagant component. Because of nature of the combination with intermediate and short acting component have the peak action around 1 hour. So that need to be given with meal. For example, Humulin mix 30 10 unit with breakfast and another 10 unit with bedtime. Usually this is the BD dosing regime we use in type 2 diabetes mellitus. This is a slice for information, but it is very, very difficult to remember a rough idea of when they start doing the action and when the effective peak and how long they last for. If you can remember this, just ignore it and have a look at whenever you need it. But it is very difficult to memorize. So another regime we use in type 1 diabetes mellitus patient called basal bolus regime. The reason why it was called basal bolus regime is we use the basal either at bedtime or in the morning, alongside with boluses with meal, short acting. So 3 atropic, 6 unit, 3 meal, breakfast, lunch, evening meal, plus glargine or Himalayan eye at bedtime. We rarely use this regime in type 2 diabetes, but we can still use this regime in type 2 diabetes if we need intensive glucose control in severe condition like sepsis, very unwell, or sometimes recovery phase of acute coronary syndrome after stopping the variable rate insulin infusion. But usually, this regime is used in type 1 diabetes mellitus. So, if we don't know how much insulin is going to be required in an insulin naive patient, the simple calculation is 0.5 unit per kg. For example, approximately 72 kg person, 72 multiplied by 0.5, total requirement of insulin could be 36 units in 24 hours. So this 36 units simply divided half into basal and other half into boluses. So by dividing this 36 unit into half, we will get 18 unit given as the basal, as a glargine or Himalayan eye, 18 unit at bedtime, and another half of the total insulin requirement, 18 unit, we equally divide it into 3. 6 multiplied by 3 times, 6, 12, 18. These boluses to be given with pre-meal as Atravit or Novorapid. This is the basal bolus regime we use mainly in type 1 diabetes. So in type 2 diabetes mellitus, we usually use mixed insulin twice daily regime with pre-breakfast and pre-evening meal. The same thing applies to the previous slide. For the 70 kg person, total daily requirement is 36 units. You can still divide it into equally 50%, 18 in the morning, pre-breakfast, and 18 at evening meal. But to prevent the risk of overnight hypoglycemia, we intended to give a little more insulin before breakfast and a little less insulin before evening meal to prevent overnight hypoglycemia. For example, maybe 24 units in the morning, 18 in the pre-evening meal. This slice is a little busy slice. The second part of this slide is actually for the community visit. How to monitor and titrate the insulin in the community. The first part is we usually use in the hospital. So this slide actually explains the previously discussed how much insulin are we going to use for a patient. We don't know the requirement of the insulin. So you can see we were told that 0.5 unit per kg per day. So this 0.2 here is actually applied for long-acting component of the pre-mixed insulin. So actually, during the previous slide, we said that 0.5 unit per kg. Actually, 0.5 split into two. 0.3 is the short-acting component and 0.2 is the intermediate-acting component. For example, 10 unit of pre-mixed insulin. 2 unit is mainly for Himalayan eye and 8 unit for atrophic. Actually, this slide is extra. slide that we already have discussed earlier. Actually, the important thing for this slide is the last line. Actually, 1 unit of insulin will deal with 2 millimole. I would say 2. Forget about zero point 0.8. 1 unit of insulin will handle with 2 millimole of blood glucose control. For example, if you want to reduce 10 millimole of glucose, you have to use 5 unit of insulin because every 1 unit of insulin will deal with 2 millimole. So if you want to tackle with 10 millimole of glucose, you have to use 5 unit of insulin. Here's another rough guide. If the amount of glucose you are going to fight is less than 10 unit, just +1. 11 to 20 unit +2. More than 20 unit probably need a +5 to the previously given dose. There's a re-explanation of the previously discussed mixed insulin. Human mix 30, human mix 50. The same thing, we can still use that 0.5 unit per kg. Actually, this 0.2 is talking about the, if you are worried, can start with a slightly lower dose. 70 kg man 0.2 unit, total daily requirement 14 unit. You may split 7 unit pre-breakfast, 7 unit pre-evening meal. If your patient is obese and high insulin resistant, you may use 0.5. So it's going to be 36. So you may use a 18, 18. Or you may use a little lower dose in the pre-evening meal. Let's say 24, 12, something like that. To prevent nocturnal hypoglycemia. We are going to discuss some real case scenario. This is a patient with type 1 diabetes mellitus. We know that inpatient glucose target is 5 to 12 millimole. We don't want someone blood glucose to be lower than less than 5, and we don't want more than 12. This patient is receiving Novorapid 3 times 8 unit, 24 unit, and glargine as a basal 10 unit. So this patient is needing 34 unit of total daily insulin. Why getting this? These are the blood glucose while on this regime. He wake up with 16, pre-lunch, getting high at 22. There's a reflection of this breakfast. Boost is not covering to the lunch. That's why the lunchtime glucose is getting higher. So this pre-breakfast dose need to be increased because the previous dose given will influence on the pre-next meal glucose. Again, Novorapid 8 unit given at the pre-lunch is not able to cover. So the glucose is getting higher, 30 unit, 30 millimole before the evening meal. The same thing apply. Pre-evening meal, 8 unit given, not able to cover the bedtime glucose within the range. So that need to be increased. Again, glargine given at the bedtime is influence for the next day breakfast. So the patient wake up with 16 unit with out of range of the target mean that the glargine given at the bedtime earlier night is not enough. That means that all the bullets, beta and the boluses need to be increased. So how are we going to adjust? So let's say, 16 is the patient glucose. We're targeting for 12. So 16 minus 12, we will get 4. So you are going to find with at least 4 millimole of glucose. 1 unit of insulin is covering 2 millimoles, so you will need additional further 2 units of insulin. So new regime will be lower rate become 10. Here again, patient glucose is 22. Our target is 12. 22 minus 12, you will get 10 millimole of glucose. So for every 2 millimole, 1 unit of insulin increment is required. So 10 millimole of glucose need 5 millimole of insulin to be top up. So 5 plus 8 will make it 13 units. Our new regime is now Nuboravit 13 pre-lunch. Evening meal 30 minus target 12, you have to find another additional 18 millimole of glucose. So you need to top up 9 units of insulin. So it's going to make 17 units with the evening meal. So new regime will be 8 plus 2, then 8 plus 5, 13, 8 plus 9, 17. Here, 16 minus 12, equivalent to 4 millimole. So you needed 2 units of insulin to be top up. So make it glycine 12. So new treatment is going to be 10, 13, 17, 12. Let's see what happened next day. This is the next day glucose. After increasing this new regime, the next morning, the patient wake up with the glucose higher than previous day before you change the dose. That means that this glycine seems not covering this breakfast. So are we going to increase this glycine further or not? So other pre-lunch, pre-evening meal, and pre-bedtime glucose seems to be getting better with the new treatment regime. The problem is how to tackle with this breakfast hyperglycemia. Don't forget there is a Somoji effect. That Somoji effect is because of we increase the bedtime glycine, in reality, around 2 to 3 a.m., patient develop hypoglycemia, less than 3 millimole. Because of the counteracting mechanism to prevent the crisis to the body, all the counter-regulatory hormones came out as a stress. So cortisol, glucagon, adrenaline, growth hormone, everything come out to prevent further hypoglycemia. After that, they all can cause hyperglycemia. So because of all the counter-regulatory hormone effect, the patient wake up with hyperglycemia. This is called the reactive hyperglycemia to early morning hypo. This is called the Somoji effect. So in such condition, we need to make sure that the patient didn't have early morning hypoglycemia by checking the 2 a.m. That's the reason we check the 2 a.m. blood glucose. This patient found out to be blood glucose of 3 millimole. In this situation, instead of increasing the nighttime dose, you have to reduce pre-bedtime dose to prevent early morning hypoglycemia causing reactive hyperglycemia in the morning. So it is very important to know the 2 a.m. glucose to adjust the dose of insulin. If hypoglycemia, reduce the bedtime dose. If no hypoglycemia, this is real hyperglycemia. We need to increase the bedtime insulin. Actually, real hyperglycemia is called Dawn phenomenon. It's just a name, Dawn effect. Dawn is the early morning effect, dawn attack. And hypoglycemia causing hyperglycemia is called Somoji effect. During the insulin therapy, it's not possible without touching fixed rate intravenous insulin infusion and variable rate intravenous insulin infusion. So I'm not going to talk detail into DKA or HHS or whatever, but just light touch. So as a provision, to be labeled as a DKA, we need to have all three criteria to be present. Nowadays, we rarely use the urine ketonuria, blood ketone above 3 millimole, blood glucose above 11, and venous pH of less than 7.3 or bicarbonate less than 15. We need to have the three all criteria to be present. Be careful with the glucose value. Sometimes glucose is not high. Then we between the range of 5 to 11. It is called normoglycemic DKA or euglycemic DKA. That can happen especially in patients taking SGLT2 inhibitor, dapagliflozin, empagliflozin patient. They can present with euglycemic diabetic ketoacidosis. So I would say blood glucose criteria is not absolute necessary for the diagnosis of DKA. This is the usual pathway we used to see everyday life when we managing diabetic ketoacidosis patient. Even though FRIII, fixed rate intravenous insulin infusion, insulin is the fourth component of the regime. The other three important components are the fluid, potassium, glucose, plus insulin. So there are four components. First component, fluid management. We know that 1 liter in 1 hour, 1 liter in 2 hours, two times, and 1 liter in 4 hours, two times, and 1 liter in 6 hours, two times. So the first liter is the very first fluid, 1 liter over 1 hour. So we know that potassium cannot be given faster than more than 10 millimole per hour. Usually, potassium shouldn't be included in the first liter. But starting from the second liter, given over 2 hours, the maximum potassium can be added is 20 millimole. Starting from 4 hour to 6 hour regime can be added to 40 millimole. It depends on how the potassium level. No potassium if potassium is above 5.5, 20 millimole, or maybe 40 millimole if potassium is between 3.5 to 5.5, and potassium 40 millimole if the potassium is less than 3.5. You may need a more concentrated potassium in shorter duration of time through the central line in the high dependency setting. These all fluid should go along with 10% glucose if the blood glucose less than 14 millimole. It can be additional 10% glucose over 8 hours in addition to this fluid, or if there is a risk of fluid overload and acute pulmonary edema, you can replace by combination with dextrosaline instead of can go parallel if you have additional lines. So we all know that there's a fixed rate intravenous insulin infusion. The reason why it was given the name as fixed rate is regardless of the glucose level, until TKA resolve, we will never change insulin according to the body weight. So 60 kg, 6 units, 70 kg, 7 units, 80 kg, 8 units per hour, 90 kg, 9 units per hour. For example, 9 units per hour, if the glucose began 10, we will still use 9 units per hour with the additional 10% glucose infusion parallel. Please be aware that this fixed rate intravenous insulin infusion should be continued until ketosis fully resolved, less than 0.6, and the age should be recovered very well, pH above 7.35, or bicarbonate more than 18, or base excess more than -2. But base excess takes time to recover for 24 to 48 hours. Sometimes, as far as pH and bicarbonate recover, we may probably ignore base excess of -10 sometimes. So sugar control is, if not well, we can give 15 units per hour up to, even though the body weight is not 150 kg. So once DKA resolved, we used to change to variable rate intravenous insulin infusion. We know that the indications are cannot eat and drink because of vomiting, but make sure that you need to rule out the DKA. Some of the condition, we need to keep the patient nil by mouth because of risk of aspiration or waiting for the salt assessment the next day. Or sometimes surgical preoperative procedure need the nail by mouth. We better put them all on variable rate insulin infusion. And in some conditions of severe illness, like severe sepsis, recover from the ACS after 48 hours, and HHS, hyperosmolar hyperglycemic syndrome, it's safer to put them on variable rate intravenous insulin infusion. And last not the least, anybody with the troponin rise, chest pain, ECG changes, with the blood glucose of 11, by giving the variable rate intravenous insulin infusion, intensive glucose control for 48 hours can increase outcome. So we know that variable rate insulin infusion because we are going to adjust the rate of insulin infusion according to the hourly monitoring of blood glucose level. This is a usual chart we use in daily life in our what? It has column A, column B, column C. For example, blood glucose 5, we will get the 0.5 unit of insulin. Glucose 24, if we are using the column C, we are going to give the 8 unit per hour. Sometimes glucose is out of range, 30, 35, something like that. We can add additional column by +2 or +4. It depends. But that usually need discussion with senior member or the colleagues. I'm not going to talk about insulin pump detail in this discussion. You may encounter a patient because we are talking about the hospital diabetes management. So you may encounter the patient coming with insulin pump. Usually NHS won't allow to use insulin pump for type 2 diabetes. So almost all patients coming in with insulin pump are type 1 diabetes. Insulin pump can go wrong at any point. Can be the machine failure, can be the catheter failure, can be the subcutaneous needle problem. There's a continuous glucose monitoring lever. So, as the inpatient management, whenever you deal with insulin pump with hyperglycemia crisis, the first thing you need to do is stop the pump. Ask the patient to stop the pump. They know very well how to manipulate their machine very well. Stop the pump and put them on variable rate or fixed rate insulin infusion or basal bolus regime as required. And insulin pump can be restarted once the condition is stable or reviewed by member of the diabetes team. So roughly they have their individualized calculated insulin requirement for 24 hours. The pump is giving the insulin continuous infusion basal. And the patient can top up the boluses at the meal by top up insulin. And they have their individualized calculated insulin sensitivity. So they know that, for example, 10 gram of carbohydrate eating the 1 unit or 2 unit need to top up. They know by themselves. Usually listen their advices. And usually they know how much they should top up. They were very well trained. So I'm going to finish this discussion at this moment. If you have any questions or answer, you may wish to ask by email or in person. Thank you for listening. Thank you.